Well, welcome back, and Dr. David Grimes has kindly agreed to come back and talk to us yet another time, despite yesterday. So, thanks for that, David. Great for you to come back. Nice. Now, today we want to... You're basically been a lifelong physician. You're a consultant physician. You're a medical researcher. You're a medical author and medical teacher. This is what you've dedicated your life to, and you're also a leading pioneer in the issue of vitamin D, recognising the widespread deficiency of vitamin D and the multiple conditions that are predisposed to it. People don't have adequate levels of vitamin D. Yeah. What is it got you in? When and why did you first get interested in this topic?
Much of what I've learnt during my working life has been learning from patients. People tell me their stories, and it somehow all fits together. And a number of people told me their life stories and the illnesses that they'd had during their lives. And so much of it revolved around vitamin D deficiency. I didn't realise that at the time, but I had to put two and two together, work out the common factors. And the people in particular were in... I was working in Blackburn, which is a poor town in the northwest of England. And there's a lot of poverty in the town. The poor people were the predominant patients in the hospital where I was working. Also, the ethnic South Asian population had a large degree of illness, great degree of illness. And putting it together...
These were basically first-generation immigrants in this time, so we're talking about 1970s, 80s,
yeah,
90s.
That's right. Yes, indeed. But it continued in the second generation as well. That's the important thing. And so putting together the northwest of England, the British Isles at a fairly northern position on the globe, the poor people, the South Asian ethnic people, and the common factor was vitamin D. There was a great shortage of vitamin D. And I then undertook quite a lot of research into vitamin D levels, looking at about 5,000 people and the vitamin D levels.
This is a sort of 1980-ish?
Yeah, that's right, 1980s. And it was staggering how much deficiency of vitamin D there was, especially in the South Asian population.
You were finding a difference in the levels between the white population and the Asian?
Well, basically... about 85% of the white population were vitamin D deficient.
Wow.
And about 95% of the South Asian population were severely vitamin D deficient.
It's just staggering numbers, isn't it?
Absolutely terrible.
Yeah.
And it can always be put right.
Of course.
Now, social deprivation is not an easy thing to correct. And as a physician, I was not in a position to improve social deprivation. I was there to reduce illness. And some people would say, well, rather than reducing illness directly and treating people, you should have put right their social deprivation. Well, I couldn't do so.
Yeah, you don't have a magic wand.
You can only do, as a physician, I could only do what I was capable of doing, what I knew what to do. And one of those things was, of course, correction of vitamin D deficiency, identification and correction of it. And that's what led me for the next 30 years, research, etc. And here we are today.
What was the attitude of your colleagues at the time? Did they say, oh, this is a good idea, doctor, let's research this? Or were you... Well, how was it received?
Not in a particularly positive way, but I was really working on my own. I didn't have a department. I didn't have a team of people working with me. I was just on my own doing this.
Well, you'd have your registrar and some junior doctors.
Well, the junior doctors were involved on the clinical side, and they became aware of what I was doing. But the actual work and on the research side was purely myself. It was just on my own, really.
Wow, impressive. Yeah.
So I don't think I influenced my colleagues very much at all. But perhaps by now they might be realising there's a bit of what I had to say.
The penny's dropping very, very slowly.
That's right, indeed.
So you found this great levels of vitamin D deficiency, especially in the ethnic Asian population. What happened then?
Well, it was really a matter then of preventative medicine. And to prevent disease, correcting vitamin D deficiency, I couldn't do it. I could only deal with the people who were sick. I couldn't deal with the people who were not yet sick.
The people that came into your care.
Yeah, that's right. Yeah. That's right.
Right, yeah.
And that would need a public health initiative.
Yeah.
But I wasn't able to influence the public health side of things.
Yeah. I mean, even at that early stage, as a pioneering thinker in this, were you starting to correlate the vitamin D deficiencies with specific pathologies and reasons for the patient's admissions?
Yeah. Yes, I was. The first one was tuberculosis,
right,
which is well established as being due to deficiency of immunity. So that happens with the South Asian population.
Yeah. So tuberculosis is basically a chronic bacterial, often lowish grade, or I mean,
that's right.
It can rumble on for years, tuberculosis.
It can indeed.
Yeah.
Ultimately killing, but going on for a long time.
Yeah.
Slowly reducing levels of health and gradually leading
awful.
to
Chronic
death.
morbidity for years, and then you die.
That's right.
Yeah.
I'm afraid so.
Yeah.
That's right. That's right.
Yeah.
It's sad.
Yeah.
So what was happening actually with the South Asian population, there's a colleague of mine, Professor Peter Ormrod, and he took the lead in tuberculosis. And he and I talked together about this with the South Asian population. And there are other publications which showed that people who came to this country from South Asia, they didn't have tuberculosis when they came. But they developed it, and this has been researched by other people,
Really?
they developed tuberculosis about 6 to 8 years after they arrived in this country.
I assumed that it was fairly endogenous in South Asia, and they just brought it with them. That's not the case.
Well, they brought the bacterium with them.
I see.
But the disease was latent.
I see.
The disease was latent.
Yeah.
And they come to this country, and after about 6, 8 years, suddenly they became ill with tuberculosis. It had been activated. It had been activated by no vitamin D, no sun, entirely different environment from where they came from.
So in sunny environments, they're making enough vitamin D to keep. Yeah. While they didn't eliminate the bacterium, it was still there, but it was kept. It was kept down by sub-pathological levels.
Yeah, it was kept down by our immunity. And immunity is so vitally important.
Yeah.
And the tuberculosis is kept under control by immunity, which depends upon vitamin D. Without vitamin D, immunity doesn't work, basically. Well, there are other reasons why immunity doesn't work. One of them is AIDS, acquired immunodeficiency syndrome due to HIV, the virus. And that virus damages the T cells. Now, that's one way in which the T cells, the T helper cells, don't work properly. But the other way is because T cells require vitamin D to escalate the immunity. Without vitamin D, the immunity cannot be escalated and the T cells don't work properly and disease occurs, such as tuberculosis.
Yeah.
And this is cellular immunity, not the antibody immunity.
Yeah.
Cellular immunity.
Yes, these immune cells will actually attack the bacterium directly or attack an infected cell.
Yeah,
cellular
exactly,
immunity, as opposed to humoral immunity, where the antibodies were floating around in the body.
So this is the important thing in the South Asian population coming to England, is they didn't catch tuberculosis when they came to England.
Yeah.
But being in England or Scotland,
even worse.
Wales or Ireland, activated the disease.
Right.
And so what's that all about? It's because they're no longer getting vitamin D from the sun, and especially if they are, and it was more common actually in some research in the Hindus who did not eat meat,
right. Less fatty food, perhaps,
less fatty
in
food.
general.
So they were not getting any vitamin D from the diet, let alone from the sun.
Interesting.
And it was very sad to see it happening. Ideally, what should have happened is that, well, let me give you another example. If we're going to a tropical area, we find out if there are any diseases there that we don't want to catch, such as malaria.
Yep.
And if it's a dangerous place, well, you don't go. But on the other hand, if you need to go there and there's malaria, you take an anti-malarial treatment. Fine. That's an initiative that should have happened when people came from Asia, South Asia, to England. the question should have been put to them, or the statement should have been made to them, when in England, you're going to become vitamin D deficient. You must take vitamin D when you're in England. But no one told them that.
See, I remember at that time in the early 80s,
Yep.
learning that there was a huge amount of tuberculosis in the South Asian, especially population. And I didn't realise it was vitamin D deficiency. But why didn't the respiratory physicians around the country realise this?
Well, some of them did.
Right.
No question, some of them did. They
Right.
put two and two together. This is particularly so in the London hospital in London. There's a great awareness of vitamin D deficiency, going with tuberculosis. Now, it was realised 100 years ago that there was a lot of tuberculosis in the poor people of Glasgow.
Yes.
And there's a lot of rickets as well.
Yes.
The rickets, due to deficiency of vitamin D and tuberculosis, went together among the poor people in Glasgow.
So rickets and tuberculosis both common in the slums.
Yeah. Association, as they say, is a clue to cause. The two conditions are associated.
That is such an important. It's such an important point. That association is a clue to causality.
Yeah, absolutely.
You know, whenever these days you say, "Well, there's an association here," and there's always I wish I had £1 for every time someone had sent me a message saying, "John, correlation is not causality. Don't you realise this?" Yeah, well, I do realise this, but.
Yeah.
You know, if there is a causal relationship, there'll also be a correlation.
There will indeed, absolutely.
So let's stop poo-pooing correlations and say, correlation, interesting.
Yeah. So here we have it. Association is a clue to cause. Now,
absolutely.
Is a clue to cause. Now, the point is, of course, if you're interested in your work and life in general, you look out for clues, and a clue makes you stop and think. It doesn't prove anything, but it makes you stop and think, and then you can take it a stage further.
And sometimes you may just dismiss it in a few minutes.
Yeah,
but
absolutely.
at least you should stop and think about it and not automatically. Yeah, it's got to mean something. Yeah, absolutely.
Well,
we are pattern recognising creatures, aren't we?
We are exactly. Recognising patterns.
Yeah,
all important. There's a Dr. J.S. Hutchinson in Glasgow decided to investigate this further, and he went to India.
Yeah.
And he had...
This is when?
This is 1926.
Oh, wait, well, this is way back. Right, okay. So the association between rickets and tuberculosis
was in Glasgow.
Observed. Right.
Yeah, it was in Glasgow.
Yeah.
Let's have a look at India.
Interesting.
He had the opportunity to go to India as part of the British Empire, as it were.
Yeah, and we can learn so much from cross-cultural comparisons, can't we?
Very much so.
Yeah.
Anyway, he was in Bombay,
right.
and he was assisted by a man called, I think it was Mr. Shah, whatever it was anyway.
Yeah.
Hutchinson and Shah. And they produced a wonderful monograph of this. And what they found out is that tuberculosis, or did they start with, I'm not quite sure if they started with rickets or tuberculosis.
Yeah.
But anyway, they found out that they coexisted. And they coexisted in the wealthy people. The poor people were much, much healthier. And the wealthy people in Bombay, they were the ones who got tuberculosis and the children got rickets.
Right, so it was the opposite way round to Glasgow.
That's right.
Yeah.
See, the wealthy people, they were able to stay indoors.
Yeah. Yeah.
Away from the sun.
Yeah. Whereas in Glasgow, the poor people were working in the mills and the mines.
Yeah, that's right. Indoors.
Yeah.
And the wealthy people were out in the gardens and the suburbs.
Right.
Whereas the poor people working out in the fields of India, they were the wealthy. They were the healthy ones.
That's so simple, isn't it? So in Glasgow, the wealthy got plenty of sun.
Yeah.
And in Bombay, the poor got plenty of sun.
That's right. Yes, indeed.
It was the other way around. Yeah.
This is a brilliant bit of research that they did.
Yeah.
I love reading the book that came out of it. I've not read it recently.
And before we carry on with that story, this, to the people in Bombay and the people in Glasgow, that would have been so obvious.
Yeah.
They wouldn't have thought of it.
No, that's right.
The question in my mind is how many clues to the causes of the disease we have now are blatantly obvious.
Yeah, absolutely.
And including psychiatric disorders as well as physical disorders.
Yeah.
And we just don't see it because we live with it every day.
We do.
So often what you need is someone like this doctor coming from Glasgow to Bombay.
Yes.
Where everything's new and fresh, and seeing it with fresh eyes and realising the...
That's right.
Anyway, he sussed this out, did he?
He did indeed. And he get very careful records of the people who he interviewed and visited in this area of Bombay. It's a very, very thorough piece of research. I don't know how influential it was. I know one thing, it influenced me in a very big way.
Yeah.
I thought it was absolutely brilliant. And I paid a lot of attention to it.
And did he realise it was vitamin D then?
No, it's just the sun.
Right, so he knew it was the sun.
Yeah, they put the two together. It was the sun.
So was knowledge of, vitamin D was known about in the 1920s, was it?
Yeah, but in Glasgow in particular, it was considered to be a dietary factor.
Right.
Because when children with rickets in Glasgow were sent home to the coastal villages and given cod liver oil and eating fish, they improved.
So
there was a
rickets,
dietary factor.
People have never seen rickets. Just tell us a little bit about it. What is rickets?
Well, rickets is a disease of growing bone, where the bone doesn't grow properly. Bone starts off as a sort of fibrous cartilaginous matrix, and then it becomes ossified by the addition of calcium.
Yeah, so it's quite flexible when you're a child, isn't it?
Absolutely. And when babies are in the first year of life, the rickets it becomes obvious with where the ribs join the sternum, and also on the wrists as well.
The ring of beads. Yeah,
that's right, and on the wrists.
So the joints between the cartilage and the bone in the chest is not joining up properly. Not joining up properly.
No. Yeah. Now once a little 1-year-old starts to walk and becomes a toddler, then the weight of the body is on the legs. Yeah. And so the legs deform. And so we get the bow legs of rickets at that time.
Yeah, because the bone's soft and flexible.
Only when they're toddlers,
And this, of course, is why children often get green stick fractures. Yeah. The fracture doesn't go all the way through because the bone bends. Yeah. Whereas yours and mine's will just snap like an old dry twig.
Indeed. And the bad part of it when they're toddlers also, and young children, is in girls. Yeah. The femur, the head of the femur, the hip, would push into the pelvis, and the pelvis would deform and narrow. Yeah. So when they came childbearing age, they had a dreadful time with childbirth, because the pelvis wasn't big enough for the baby to go through.
So women want a nice wide pelvis to facilitate the fetal head going through that. And if the pelvis is small, we get a condition called cephalopelvic disproportion.
That's right.
Which is still a huge problem.
It can be, certainly.
In Asia. Yeah. I've visited fistula hospitals in Africa, where the mother goes into labour. She stays in labour for 2 or 3 days. 4 days. Eventually, unconscionable in the villages. Eventually, the baby will die. It macerates. The baby's ejected. But they're left with this the pressure effects, and you often get the fistulas. Between the bladder and the vagina. And it's all caused by this cephalopelvic disproportion, and could have been completely prevented. By early life nutrition for these poor young women.
Absolutely. Glasgow became a major centre for understanding this, and for the management of delivery in these poor women with this contracted pelvis.
The cephalopelvic disproportion.
Indeed.
And I suppose a lot of them would, in the Glasgow situation, there'd be caesarean sections.
But in Glasgow initially, as I say, because rickets could be healed by fish oils. Yes. It was considered to be a dietary disease.
Makes perfect sense, And
in fact, today, the organisation in the UK, the official organisation, which advises us on vitamin D, is the Standing Advisory Committee on Nutrition.
Yes, interesting.
Well, it's not really nutrition. It is not really a dietary factor. It was realised in Austria in particular, in the Alps, that, not in the Alps, but in the industrial areas of Austria, that children, again, were born and developed rickets. They developed rickets because their mothers were vitamin D deficient.
So if the mother was vitamin D deficient, that means the child would not be getting the vitamin D in the breast milk?
Well, it's before it's before birth.
In fetal development, right?
Yeah. It's the last 3 months of pregnancy.
Right. So it's almost like prenatal rickets.
It is. Yeah. In fact, prenatal. The main issue is brain development in the last 3 months of pregnancy,
yes.
and that requires vitamin D.
You know, I didn't know that. Really? Right? Yeah.
Another interesting factor.
Right. So vitamin D, maternal vitamin D, is necessary for fetal third trimester neurological maturation.
Yeah. Vitamin D is vital in pregnancy. See, no child should be born deficient in vitamin D.
Absolutely not. Yeah.
A little baby is not going to be exposed to the sun.
No.
And
not normally,
it's going to be protected from the sun. So the baby requires enough vitamin D, certainly to last it for 6 months.
Right.
And then it'll develop its own.
Yeah.
So the ideal time for a baby to be born is in about October, November.
Yes.
So the mother's been pregnant during the summer.
Yes. Mum's had a bit of sunbathing.
Had loads of vitamin D,
yeah.
passed it on to the baby, and the baby's born with adequate amount of vitamin D to last through the winter. And then when the baby's 6 months old, in its pram, the mother will put it out in the sun. Not to get sunburnt, of course, but in direct sunlight.
Before there's paranoia about melanoma, that was the case. Yeah.
Exactly. But that's another interesting story.
Yeah.
But anyway, going back to the babies, the time to be born is October, November.
And you and other researchers noticed the difference in children's health depending on the time of year that they were born.
Exactly. Yeah, right. The main one is the development of multiple sclerosis later in life.
Wow.
So it's childhood factors influencing their adult life.
Right.
So the risk of multiple sclerosis is highest in babies born in March, April, when the mother's been pregnant in the winter time. And the risk of multiple sclerosis is lowest in the babies born in October, November.
In a sense, that's such a simple observation, but I've taught tuberculosis for the last 30 or 40 years, and I've always taught that it's more, tuberculosis is more common in the northern, way up north and way down south near near the Arctic circles, but and less common near the equator. But
that's why
I didn't realize
Glasgow became the tuberculosis capital of the world.
Tuberculosis
basically.
Or multiple sclerosis?
Tuberculosis,
yeah.
But also, it's been the multiple sclerosis capital of the world, as that northwest Scotland.
Especially in people that were born in spring.
Yeah, that's right. And now, of course, at long last, vitamin D is being used in the treatment of people with multiple sclerosis.
Yes. And I've certainly had, 1,000 emails and messages of people that say their multiple sclerosis dramatically improved.
Yeah.
With I must say, fairly high doses of vitamin D.
It needs to be, absolutely.
Yeah. So people with multiple
doses.
sclerosis, if they're watching this video, go to your doctor, get your blood levels checked.
Yes.
And get it bunked up.
Yeah.
So we can't tell you to take 10,000 units a day, but some doctors might tell you to take 10,000 units a day.
Yeah. Whatever's necessary to achieve a good blood level.
Titrate it.
Yeah. It's like with treating diabetes with insulin. The dose is dependent upon the blood test results, basically.
You can't say diabetics need 5 units of insulin a day. That would be nonsense. It's going to be massively different depending on the blood test for everyone.
Yeah, indeed. And the same with vitamin D. It's achieving a good blood level, which is thought to be now about 100 nanomoles per litre, which is 40 nanograms per mil.
Yes,
that's what it's
40 nanograms per mil.
But it's a matter of achieving that blood target level. If you're treating hypertension, we have a target blood pressure we're aiming at.
Of course we do.
Treating diabetes is exactly the same.
We're obsessed by HbA1c and how your glucose levels are.
Yeah, indeed.
And yet for vitamin D, don't worry about that. Forget it.
No.
So any doctors watching, titrate your patients' vitamin D levels. We would suggest. Is that fair?
Yeah, that's right.
Yeah, titrate them. Why not?
Now, in the industrial areas of Austria, the children, again, as mentioned, developed rickets because the mothers, who were working in the factories, didn't have enough vitamin D to provide them for when they were born.
And I suppose the further away they are from the sea, the less fish, oily fish especially, they're going to get.
Absolutely, they wouldn't. But what happened? We know the Heidi story. The children were sent to the relatives in the Alps.
Yeah.
Away from the cities, in the high areas of farming, and they got better.
Yeah.
And so it was realised
But
in Austria...
it wasn't known why, they just did.
But it was realised in Austria, the key was the sun.
Yep.
Whereas in Scotland, where they didn't get much sun, the key was the fish.
Right.
And it was really, that's why vitamin D was regarded as being a vitamin, an essential thing that we can't produce ourselves.
I see, yeah.
Whereas its proper name
because it's
a hormone.
It's vital in the diet, yeah.
It's a hormone that's produced in the skin.
So interesting. So in Austria, they realised that rickets was a sunlight deficiency disease.
Yeah, yeah.
In Glasgow, they realised it was a dietary deficiency disease.
Yes, that's right.
And I suppose if you're 10,000 feet up in the Alps, you've got so much less atmosphere.
Yeah, yeah.
I would assume you'd make vitamin D more quickly than you would at sea level, would you? Is it appreciable?
There's much more ultraviolet light at a high altitude, yes, indeed. But it's just being in the fresh air and getting the sun.
Yeah.
So basically, when people are short of vitamin D, it's not a nutritional issue, it's a hormone deficiency. Yeah. And when we take a vitamin D supplement, when we take a vitamin D supplement, it's a form of hormone replacement therapy.
Yes.
And so is it. So is diabetes.
Yes, of course it is.
We give insulin. It's hormone replacement therapy. When someone has an underactive thyroid and we give thyroxine, it's hormone replacement therapy, as well as the estrogen deficiency that follows the menopause in women. And so it is with vitamin D. Yeah. We're giving hormone replacement therapy. We have to achieve
or
the target level.
Addison's disease, where you might want to give some steroids.
That's right. It's another one, indeed. Addison's is another one, indeed.
So interesting, tying those things together.
It is indeed.
So you better show this book off, David, that you've got here. What is this text here, and where can we buy one?
Well, this is the book that I wrote. I think it was 1999.
And I must say, it's probably the most readable medical textbook I've ever read. It is so... The intelligent lay viewer would have no difficulty with that at all.
It was written not for doctors, it was written for... the general public.
And that comes through.
To understand.
Yeah.
So the book can be a bit tedious.
No, I don't
with a lot
agree.
of medical knowledge.
No, if you know lots and lots of stuff, I suppose. But no, I don't. Even so, I don't think so.
We've got to think about what diseases, etc.
Yeah, yeah.
But I've started the book off. I said I learned a lot from my patients.
Yes.
And can I read a bit about Abdul?
Please do.
I'll just read this to you if you don't mind.
Yeah, no, please.
I can't remember it all, so I'll just read it out of the book. Abdul was born on 22nd of October 1961 in Pakistan, in a village close to Rawalpindi. The family was poor. His father worked on the land, but his mother did not work outside, staying in the house most of the time. As far as he can remember, his mother wore a headscarf, but she did not cover her face. Abdul did not go to school, but he would spend his days playing outside with the other boys. In 1971, the family came to live in England in search of a better life. They settled in Oswaldtwistle in Lancashire, where his father obtained employment in a textile mill. Abdul went to school in Oswaldtwistle, but he did not play out very often. They lived in a terraced house without a garden. The textile mill in which his father worked closed down, but he was able to obtain work as a labourer in a cement factory. And the family moved again, living in a small terrace house. After leaving school with no qualifications, Abdul worked in a factory as a battery filler. In England, 2 more children were born to the family, but they were not as healthy as Abdul was in childhood. One suffered from learning difficulties and the other was congenitally deaf. Abdul had always been of low weight, small in stature, but in 1993, at the age of 32 years, his health deteriorated. He visited his family doctor with symptoms of lethargy. He was 52 kilograms in weight, and initial blood tests showed he was anemic. Further investigations showed that he had advanced kidney failure. He was clearly critically ill, and his family doctor therefore arranged for him to be admitted to the hospital as a matter of urgency. Full assessment included ultrasound scan, which showed the kidneys to be small and shrunken. the result of progressive inflammation over a period of perhaps 10 years, usually driven by an immune process. The disease was not reversible. Abdul was started on life-saving dialysis and put on a maintenance programme. In 1996, he received a kidney transplant. On further investigation, he was shown to have low serum calcium level in the blood, and the serum parathyroid hormone concentration was high. The combination of the two indicated biochemical features of osteomalacia, the adult form of Rickets, the result of vitamin D deficiency.
Basically, isn't it?
Soft bones, yeah. He was given vitamin D supplement that was necessary. However, the supplement had to be stopped quite early because his blood calcium level rose above the normal range. He developed what's called tertiary hyperparathyroidism, a rare but well-recognised complication of advanced chronic renal failure. In 1995, Abdul sustained a fracture of the scapula, an unusual fracture that was almost certainly a manifestation of continuing osteomalacia. The next development was 1997, when he developed enlarged lymph glands in the neck, cervical lymphadenopathy. Chest X-ray showed enlarged lymph glands in the chest, and biopsy of the neck glands confirmed the clinical suspicion of tuberculosis, and he was given a 6-month course of treatment with rifampicin, isoniazid and pyrazinamide. In 1998, Abdul developed sudden onset weakness of his left arm. This was because of a cerebral infarction, a stroke. In 2001, he was admitted to hospital as an emergency because of a sudden onset of chest pain. ECG showed features of myocardial infarction, heart attack. On that admission, he was found to have high blood glucose levels, and a diagnosis of diabetes was made. He later went on to receive treatment with oral hypoglycemic agents. In 2002, his kidney function deteriorated, and it appeared that the immunological inflammatory process of glomerulonephritis that had damaged his natural kidneys was now damaging his transplanted kidney. In October 2004, he was admitted as an emergency because of sudden onset of weakness of the right leg. He had sustained a further cerebral infarction, a stroke. Blood tests showed deteriorating renal function. Despite the huge burden of illness during the past 10 years, Abdul remained cheerful and optimistic. This was the last time I saw Abdul. In December 2004, he developed a staphylococcal septicemia. Despite full intensive care support, his kidney function deteriorated rapidly, and he died. His age was 43 years. The good life that Abdul's parents expected for their children had failed to materialise.
Poor guy. I mean, dear me.
Yeah.
Renal failure, which is horrible.
Yeah.
Tuberculosis, strokes, myocardial infarctions, diabetes.
Yeah.
It's a life of chronic ill health.
Yeah, it is, absolutely.
But what's let's maybe the relationship between renal failure and vitamin D? What's the thinking there?
Well, osteomalacia.
Yeah, so that's basically soft. So he didn't have rickets because when he was playing outside in Pakistan, he had plenty of sun.
Yeah.
So he was healthy when he came to the UK.
He was healthy when he came to the UK.
Then because he didn't have enough bones, he wasn't mineralising his bones, and they went soft.
Yeah.
And he got osteomalacia.
What we know about kidney failure, it's far more common in the South Asian population and the Black African population in this country.
Yes.
In the UK.
Yeah, I knew that. Yeah.
And it's thought to be because of, it's one of these immunological things where vitamin D deficiency is a major factor.
So glomerulonephritis, as I understand it, is an inflammatory disease of the kidney stimulated by infection with autoimmune processes after that.
Yeah.
So it's all related to initial infection and ongoing autoimmune factors. And we know that vitamin D is massively important in the initial infection.
Yeah.
And is vitamin D important in modulating autoimmune pathologies, autoimmune diseases?
It certainly seems to be associated, no question about that. With the kidney, when people get kidney failure, they can get vitamin D deficiency as a result of the kidney failure, as well as it probably causing the kidney failure in the first place.
Because the kidney's activating the
very
vitamin
complicated
D.
story.
The kidney's activating some forms of vitamin D, isn't it?
Yeah.
Yeah.
But we can see that, Abdul, all these diseases that you developed were all linked to vitamin D deficiency.
Yeah, so it's quite possible if he'd been vitamin D replete all his life, he might never have developed that.
Yeah, that's right.
The tuberculosis we've already discussed, clearly.
Yeah, that's right.
Bacterial infection.
Yeah.
Vitamin D is a huge factor.
Yeah.
I'm not so sure about the vascular disease. So he had a myocardial infarction, he had a cerebrovascular accident.
Yeah.
What's the kind of linking there?
Well, heart attacks are very closely linked to vitamin D deficiency.
Yeah.
No question about that.
Do we know why that's certainly true. Do we know why it is?
Well, this is another story.
Let's have it.
Why do people get heart attacks? What is the nature of the disease that leads to what we call myocardial infarction?
Right. So what I taught for a couple of generations was it's due to fatty accumulation, atherosclerosis in the arteries, clogging up the arteries, meaning the blood supply to the tissues is reduced and making blood clots more likely.
Yeah. Well, that's basically true.
Oh, that's good. Because I found out so many things I've taught all my life.
Why is it? And of course, that leads on to cholesterol.
Yes.
It's all due to cholesterol.
That's what we were taught.
Yeah.
Ansel Keys.
You know, personally, don't believe it is due to cholesterol. I think that the disease is due to infection in the arterial wall.
And chronic inflammation.
Yeah, and chronic inflammation. And as we know, we need vitamin D to control, subdue infection.
Yes.
Keep it under control.
Yeah.
If we're short of vitamin D, then the infection, the inflammation takes over and becomes more severe.
Yes.
Well, people say, well, how on earth can a disease of the coronary arteries...
The arteries to the heart, the arteries to the myocardium.
Why can it be due to infection? Yeah. Well, what else is it due to? People say, well, it's due to diet. Well, what do you mean, diet? But there've been loads of ideas about how diets can be bad for us, especially high cholesterol diets, high fat diets. And this has been the story for nearly a century.
Well, for my working life.
Yeah, absolutely.
Since the mid-70s up until I only learned the more modern thinking perhaps in the last 10, 15 years.
Yeah. But dietary manipulation has not been a benefit, I'm afraid to say. So people say, well, it's due to cholesterol. Well, cholesterol is an important part of the body.
Yeah.
We make cholesterol. Why on earth should cholesterol be... should we make cholesterol if it's going to be poisonous to us? And so it doesn't make a lot of sense. Now, the fat in the arteries is this LDL cholesterol, which is part of the body defense mechanisms. So you might say, why are there a lot of firemen at the scene of a fire?
Yes.
Are they pyromaniacs? Are they setting fire to their places?
Yeah.
Well, they're not. They're there as defenders. Why are there a lot of policemen at the sign of crime? Or are these policemen criminals? No, they're not. Why is there a lot of cholesterol in the tissues of the heart? It's there as a protective mechanism, secondary mechanism.
Interesting.
Because that's the first line of defence, really.
I mean, I remember I worked on coronary care in the late 80s, and the people used to come in with huge myocardial infarctions.
Yeah.
Almost like boils inside the arteries that would just burst.
That's exactly what it is, like a boil inside the artery. Yeah.
And they had huge amounts of damage to the heart.
Yeah. Don't see it now.
You see it less.
Those severe myocardial infarctions with ECG changes don't see at all now.
Yeah. We used to call it, we used to say, not in front of the patients, I hope not, but, we'd call it tombstone ECGs. Because the ST elevation would be like a tombstone.
I've not heard that expression, but it sounds very
massive
nicely.
Change, just massive ST elevation,
The thing about the deaths from myocardial infarction, deaths from heart attacks, the disease started about 1926.
Interesting.
And it's been very, very clearly recorded in this country, from England and Wales in particular statistics, the onset of the disease in about 1926, and it rose and rose into the time of the Second World War. But then people weren't interested in disease then, they were interested in survival from a war.
Yeah.
And it reached its peak in 1970. Now, in 1970, I was the resident medical officer of the Manchester Royal Infirmary. And every day we saw people brought in, absolutely clapped out, dreadfully pale, shocked,
whitish sheets,
pouring with sweat,
sweaty,
chest pain,
shocked, excruciating pain, terrified.
That's right.
Horrible.
And the chance of death was very high.
Very high.
Now, before then, we didn't have coronary care units, but we had to have coronary care units then because we were suddenly dealing with something that hadn't happened before.
Yeah.
It was the peak of an epidemic. It was a pandemic, really. It's all over Europe, North America in particular. And then it declined. And it declined almost completely in the first decade of the 21st century.
Interesting. It
didn't decline because of statins, because 80% reduction had taken place before statins were invented.
Yeah. The trend was well and truly down.
Yeah. Another interesting thing about statins is that they were developed as an antibiotic.
Were they?
Yeah. They know out 1972 in Japan. And they found to have a serious side effect, reducing the cholesterol level of the blood.
Right.
So they couldn't get approval with a side effect like that as an antibiotic.
Yeah, far too dangerous.
Now, an antibiotic you take for a week and that's it.
Yeah.
Anyway, they put it on the shelf, as it were. And then later on, it became clear that what was required pharmacologically was a cholesterol-lowering agent. They said, what about that statin thingamajig that we discovered from a mould in 1972? Let's take it off the shelf, reformulate it, remarket it as a cholesterol-lowering medication. And so, the rest of the say is history.
The rest is history,
It all happened, and it's amazing. Without the benefit of cholesterol lowering is very minimal.
Yeah.
But it could be due to its antibiotic effect. That's the point. The benefits could be due to an antibiotic effect. The most effective time to take a statin is when you're actually having a heart attack. At the time when that boil is bursting in the arteries, you require an antimicrobial agent. The other thing about infection is there are three major precedents of infection causing damage to the heart.
Yeah.
One of them is syphilis.
Yes.
Syphilitic heart disease, very serious.
Yep.
Damages the aorta, aortic aneurysm rupture, damages the aortic valve in particular, and causes death, cardiac death.
Heart failure, basically. Yeah.
The next one is rheumatic fever, which was common at the beginning of the 20th century. And they had rheumatic heart disease, an infection causing damage to the valves, which would cause death. And then, of course, coronary open heart surgery came in to solve that with the valve replacement surgery. And the other one is infective endocarditis, where bacteria gets inside the heart, sticks in the heart, and causes serious damage and death there, destroying the valves also. So there are precedents to infection causing heart disease. There are no precedents to diet causing heart disease, apart from deficiency of vitamin B1, which causes beriberi.
Yes.
But that's a deficiency.
Yes.
A dietary deficiency, not a dietary surplus. But when people say, well, the heart disease is due to a dietary excess of something or other, there are no precedents for that at all. It doesn't really work. And then they say, oh, well, it's all the fast food. Now, if you look at the graph of deaths from coronary heart disease increasing from about 1926 up to 1970 and then declining equally rapidly. It's since 1970 we've had fast food. There was not much fast food before 1970.
Food, I mean, we recommend strongly against ultra-processed food for many reasons. But for this specific pathology, the amount of ultra-processed food that we've been eating has increased since 1970. But coronary arterial atherosclerosis.
Yes.
Or the atherosclerosis, the fatty atheroma in the cerebral arteries has been reducing.
Yeah.
So is cerebral... Are strokes less common than they used to be? I mean, the less cerebral vascular
It's been well recorded, the decline of strokes, the decline of coronary heart disease. It's been well recorded in the United States and in this country as well. Right. Very, very well recorded. Both the rise and the fall has been very well recorded.
But we're still... So this idea that there's potential rumbling infection inside the blood vessels...
Yeah.
You can see that vitamin D is going to be essential for combating that infection.
Yes.
But we've had a decline of cardiovascular disease since 1970.
Yeah.
But we haven't had a corresponding increase in vitamin D levels particularly, have we?
No, we haven't. But basically, if it is an infection...
Yeah.
See, there's a background of arterial inflammation. All the bacteria circulating in our blood, and it's controlled, and it doesn't cause a serious problem, but it causes low-grade atherosclerosis. That's right. Okay. But superimposed upon this, we get this boils, this really severe form, which I think was due to a new bacterium. And the research has been far from complete, but chlamydia pneumoniae is the most likely candidate. But there we are, And
that could spread from the respiratory passages.
Yeah, absolutely. And if it's a new one, if it's a new bacterium, we've no immunity against it.
Yeah.
Like with COVID-19, we had no immunity against it, so it caused an awful lot of trouble, an awful lot of deaths.
Yeah.
So, but it's gone away because we've become naturally immune to it. And the immunity is passed from generation to generation.
Now, it's not a problem really anymore, hardly.
So things, epidemics always sort of reduce.
So much we can learn from the historical patterns of disease and the geographical patterns of disease.
Yeah.
It's,
we can learn for today by looking at yesterday.
Yeah,
no question.
And the diabetes that Abdul had presumably was type 2.
Yes, it was.
Diabetes.
Yes, it was type 2 diabetes, yes, indeed.
Well, what basically is the difference between type 1 and type 2 diabetes?
Well, type 1 diabetes is basically a primary deficiency of insulin.
Yeah.
So people need insulin. The body produces approximately 1 unit of insulin an hour, on average, 24 units a day.
Yeah.
That's the basic level. Yeah. But when it goes down, when you stop producing insulin, that's when you get type 1 diabetes.
Yeah, so it's a disease of the pancreas.
Yes.
Basically.
Yes, that's right. Now, type 2 diabetes is, what happens is the body becomes resistant to the effects of insulin. So insulin stops working.
Yeah.
Stops working as well. So the blood sugar rises and you get diabetes.
Yes.
Now, the insulin resistance factors are far from clear even today. But insulin resistance is the big problem. I'm afraid vitamin D comes into this as well.
Well, that's what I was thinking. Abdul was quite thin.
Yeah.
We normally associate type 2 diabetes with obesity.
Yeah, we do.
So what's the kind of, how do we round that square, round that circle?
Well, I'm not quite sure I can answer that question, I'm afraid to say. There's so much going on in poor Abdul's life.
Yeah.
But nevertheless, he was insulin resistant. And the diabetes was diagnosed when he was admitted on account of a heart attack.
Yeah.
And that's been the case ever since with a lot of people. That's when the type 2 diabetes is usually not, people are not aware of it. It doesn't create the dangerous illness of ketoacidosis in the type 1 diabetes. It's insidious. It's
stealthy.
It's just there. It appears,
Yeah.
and it's discovered on routine testing. You might say, what's the commonest cause of diabetes? Answer is going to see your doctor.
Yeah, absolutely.
You go in thinking you're perfectly normal, and he does some tests and he found out you've got diabetes, and that's type 2 diabetes. Yeah. And he's quite right to find it, and he's quite right to treat it, because it can lead to
absolutely
very serious damage.
Yeah. So
vitamin D is very involved in type 2 diabetes. Or vitamin D deficiency is involved.
Just tell us a bit more about that. What's the thinking there?
I'm not sure there is any thinking about it, to be quite... It's
but we've noticed an association
between
low vitamin D levels and type 2 diabetes.
That's right, yeah, indeed. Yeah.
So it looks like... So it's not ludicrous to say in Abdul's case the type 2 diabetes could have been associated with his lifelong vitamin D deficiency.
No, I'm sure that was correct.
We just don't necessarily understand all the mechanisms.
I mentioned early on about disease being more common in the poor and what have you. There's some very interesting research done in Liverpool about 20 years ago. I can't remember exactly when. And they broke Liverpool down into its wards, its local government groupings around Liverpool. Yeah. And it was done by Professor Peter Townsend, was this research actually. And they broke down each according to levels of socioeconomic deprivation. And there was no question the areas of high socioeconomic deprivation, the poor areas, had a high incidence of diabetes, and those with the affluent group had a low risk of diabetes. Big social gradient there, which Townsend was very interested in.
I mean, what I would have said normally is the quality of diet that could be afforded by the poorer people. Yeah. So they're more likely to eat biscuits rather than fruit and things like that.
Yeah, could be.
Multiple factors potentially.
Yeah. The thing is, once we go into dietary factors, it doesn't really stack up in general terms.
Yeah.
Stopping people from eating biscuits. Well, I think that's a bit optimistic.
Yeah. Is there another example in the book that you mentioned? Another patient that you learnt from?
There was Frank.
Yeah, Frank. Yeah, that was it.
Do you want to hear about Frank?
Yeah, I'd love to hear about Frank. Yeah.
Okay. Hear about Frank. Frank was born in Accrington in 1943 in a household of significant socio-economic deprivation. His father had been born in 1910 but had a great deal of illness. He spent a lot of his time as a young man in a sanatorium being treated for tuberculosis. This meant that he was never able to establish regular employment. And at the time Frank was born, he was working as a part-time caretaker. Frank's mother did some work as a part-time cleaner. Frank passed through school without education, making much of an impact on him. This is a sad thing.
It's a real indictment on the system, isn't it?
Send a child to school and come out of it with no particular benefit from it.
Total indictment on the educational system.
And education is so incredibly important to health as an adult.
Yeah.
Anyway, so he left school at the age of 15 without any qualifications. He had a succession of jobs in unskilled work, usually as a storeman. He married at the age of 24 and had 2 children. The cycle of socio-economic deprivation continued, as it so often does. And there was never much money in the family. They lived in a small house close to the centre of Accrington. In his early 20s, Frank developed dyspepsia, indigestion. Yeah. And after a barium X-ray, he was found to have a duodenal ulcer. Yeah. At the age of 31 years, because of worsening symptoms, surgical treatment, vagotomy and pyloroplasty, was undertaken in 1974, shortly before the effective medical treatment became available. That is the PPIs, lansoprazole, omeprazole. He became unemployed in 1980 at the age of 37 and did not work afterwards. By that time, ill health had developed, mainly in the form of low-grade bronchitis. He had smoked 20 cigarettes a day during his adult life, but did not drink very much alcohol. At the age of 40, Frank was admitted to hospital as an emergency because of severe chest pain, which was found to be caused by a myocardial infarction, heart attack. Appropriate medical treatment was given and he made a good recovery, but subsequently developed angina. By the age of 48, he was experiencing pain in his calf muscles on walking, and peripheral atherosclerotic vascular disease was diagnosed. This was progressively worsened, causing quite severe restriction of mobility. He continued to smoke despite advice to stop. Although he was thin as a child and young adult, his weight increased when he stopped work, and this also affected mobility. In 1996, at the age of 53 years, he had a stroke, a cerebral infarction, causing right-sided weakness and severe speech disturbance. He spent 2 months in hospital and recovery was only partial. In 2012, he was admitted to hospital because of severe chest pain, the result of further myocardial infarction. He survived this further development, but he was left severely disabled and was unable to go outside. He was not able to manage stairs and slept downstairs. In 2004, he had a second stroke, which was fatal. His age was 61 years. Now,
terrible.
Frank was born...
Chronic ill health, yeah.
Frank was my age. He was born in 1943,
Yeah.
as I was born in 1943.
Yeah.
And our paths through life could not have been different.
Yeah.
I didn't come from a poor family. I didn't come from a wealthy family by any means, but not the low level of socioeconomic deprivation that Frank experienced. But it just shows how that level of socioeconomic deprivation leads to a catalogue of illnesses, like with Abdul. And I put all this down to vitamin D deficiency, which is known. Vitamin D deficiency is much more common in the poor. So he lived in a little terraced house.
Yeah.
Now, I lived in a semi-detached house as a child, and we had a garden, and we were able to play out, and we'd play with my friends, and we'd go into the garden, etc. And now, as an adult, we live in quite a big house now, with a big garden. We can spend time outside. When people are living in a small terraced house in the centre of Accrington, there's not much to do. Life is spent mainly indoors.
Yeah, and the yards used to be quite small. It wasn't really suitable for kids playing out on.
And of course, the atmosphere was much worse.
Yeah.
You know, I live in the Ribble Valley, in Glasgow, near to Clitheroe. And the standardised mortality ratio, if you take 100 to be the average national, the standardised mortality ratio where I live is about 90, which is below the national average.
Yeah.
So it's better health. The lower the number, the better.
Yeah.
Whereas Accrington, only 6 miles away, Frank would have lived 6 miles from where I live, and so would Abdul. Only 6 miles away. The standardised mortality ratio is 134. You know, 34% above the national average. It's like 6 miles. That's all.
Yeah.
And it makes a huge difference. But we live in the rural area of Ribble Valley, not in the industrial areas.
And Frank probably had vitamin D malnutrition as a fetus.
Yeah, absolutely. Yeah.
Meaning his brain probably never reached its genetic potential, which of course is a complete tragedy.
Correct, yes.
I mean, I think this is probably a global problem. I suspect there's a global deficiency, subclinical deficiency of iodine, which is necessary for normal brain development. But I hadn't realised until this conversation how important vitamin D is.
Yes, indeed.
For normal fetal brain development.
Yeah.
So if mum was deficient in vitamin D during pregnancy, instead of being a senior executive or a brain surgeon or a brilliant barrister, which Frank potentially could have been.
Yes.
And the fact that education failed him. Yeah. But very often teachers would think, you know, if this child's not showing a bit of flair, I won't bother with them. So it becomes a fulfilling prophecy.
It does
really.
Indeed. It does.
But you know, if his intellect, so it's quite reasonable to surmise that if Frank was born vitamin D deficient, that would have lowered his IQ basically. He would have been less intelligent as a result of that.
And so the socioeconomic deprivation just goes on from generation to generation.
But for biological reasons as well as sociological reasons.
The key to it, really, to my mind, a key to it, as I say, I can't alter socioeconomic deprivation. No. But I can perhaps help the results of it, minimise the effects of it. And so it would be nice if, when a woman is pregnant, she goes to the booking department at the antenatal clinic, booking in. That's the first attendance. And at that time, she has a blood test done for the blood level of vitamin D. Yep. And she's given vitamin D throughout pregnancy to maintain blood level of vitamin D. It's not asking a lot, quite honestly.
And other basic nutrients. I mean, we actually do that with some success with folic acid already, don't we?
Yeah, we do.
Because we've recognised that spina bifida was more likely in mothers that were folic acid deficient.
We test the women for iron,
Yep.
and we test them for diabetes,
Yep.
and we test them for blood pressure.
Yeah.
Well, let's do a vitamin D test as well.
Why not?
We don't test for folic acid. We just give it.
Yeah.
5 milligrams a day. Easy. The idea.
But iodine and vitamin D could be treated in much the same way, potentially.
Good indeed. Yeah, indeed. But the woman should go through pregnancy with adequate vitamin D levels. And as I said before, no child should be born vitamin D deficient. And if every child is born with adequate vitamin D development, we might see a change for the better in society.
It's almost like breaking a generational curse, isn't it? This goes on from one generation to the next. And,
You're absolutely right. Yeah.
In this case, a medical intervention could eliminate the biological component of that.
Yeah. But this is a public health issue. This isn't for me. You know, I'm a retired 80-year-old doctor.
Yeah.
You know, I'm yesterday's story. But there ought to be public health people coming up with this and saying, we've got to do something. Here's something we can do. We've been trying for years to do something about social deprivation. Now it's something we can do about it, about the effects of it, if not about the cause of it all. You know.
Absolutely. The other thing that's never been clear in my mind is, why are people more likely to get colds in winter?
Well, people are more likely to get colds in winter. They're more likely to die in the winter. They're more likely to have heart attacks in the winter. They're more likely to have strokes in the winter. They're more likely to be diagnosed with cancer in the winter.
Why?
Well, could it be something to do with vitamin D, perhaps?
It's an obvious association, isn't it?
There was some interesting work done on lung cancer. The outcome of lung cancer. The 5-year survival from lung cancer. It's not good.
No, it's still terrible.
But it's best the survival is best in the people who take vitamin D supplements and when the diagnosis and treatments are given in the summer.
Yeah.
This is a very, very nice study. Very nice study indeed. You've got a better chance of survival from lung cancer if you take a vitamin D supplement and if you're diagnosed and treated in the summer.
Interesting.
I think that might be something to do with vitamin D, you know.
Absolutely. and just an anecdotal account from me. I mean, I started taking vitamin D probably about 10 years ago, and maybe, just to people I know, maybe about 10 or 20 of them have started taking vitamin D. And consistently, they report more energy and better mood in winter. Less sad, seasonal affective disorder.
Yes.
And I'm sure. Looking back, I used to get that. I think I was pretty down in the dumps in wintertime, and I'm sure the vitamin D has been a factor in that.
When it comes to mental health, this is some interesting work. The diagnosis of schizophrenia is more likely to be in the wintertime. In Australia, it's more likely to be in the wintertime as well. But their winter, of course, is our summer and vice versa.
Yeah.
So there's a seasonal variation.
So you're more likely to get schizophrenia in the winter in the UK?
Yeah. And in the winter and in their winter in Australia.
So in other words, you're more likely to get schizophrenia December, January in England, or in May, June, July in Australia.
Absolutely, yeah. Looking at a clearer way of looking at it. So there's this seasonal variation. But when we go to Australia, we sometimes stop off in Singapore. I don't know if you've ever stopped off in Singapore. You probably have.
I have, yeah.
Well, you may know, Singapore is on the equator.
Yes.
And the research has been done there as well. And there's no seasonal variation in the diagnosis of schizophrenia in Singapore.
Because the weather's the same all year round.
Same all year round, yeah, that's right. No seasonal variation. But the seasonal variation is there in Australia and in the United Kingdom.
So we've got all these ideas. Some are hard evidence.
Yeah.
Others it's you and me.
Yeah.
Chit-chatting, really.
Yeah.
But what we need to do is make the whole country, or ideally the whole world, have an optimum level of nutrition. I mean, that statement's impossible to argue with. The whole world should have optimum nutrition. That's an axiom, isn't it?
Yeah.
And that would include making everyone vitamin D replete.
Yeah, indeed, yes.
Now, if everyone was vitamin D replete, we suspect we'd see great reductions in all these diseases.
Absolutely.
And many types of cancer.
Yeah.
And is there any reason not to make the population to have adequate levels of vitamin D? Is there any side effects or dangers to people having optimum levels of vitamin D?
No side effects at all, no problems at all. But it's like when you're treating somebody with diabetes with insulin, you don't give them too much insulin. They become unconscious.
Yeah.
So you same with people treated for high blood pressure. You don't give them too much treatment, but you monitor the treatment.
Yeah.
And I think with vitamin D also, people are going to need a supplement.
Yeah.
But they're going to need a supplement. It's difficult to get adequate vitamin D from the sun in this country.
And especially the older you get.
Yeah. Sunbeds can give you excellent vitamin D levels.
Can they? Right.
Yeah, I remember very vividly a couple of patients who I was just checking people for vitamin D, and this particular man he wasn't ill, I don't think, in any particular way, but he had an excellent vitamin D level, and he told me he visits a sunbed once a week.
Actually, I did know that because in the 1920s in Sweden, they treated rickets with basically sunbeds.
Yeah, heliotherapy, treatment by the sun. Yeah. And tuberculosis as well.
No, this was artificial light that they used in Scandinavia.
Yeah, sure.
But yeah.
Yeah.
But yeah, we used to put patients out in the sun.
Yeah.
We used to have balcony. I worked in an old unit once, and there was great big wide doors and a huge balcony, and it was built so you could wheel the patients' beds out.
Yes.
And leave them on the balcony when it was a nice sunny day.
I mentioned another couple of patients. I just learned so much from listening to people.
Yeah, it's the way medicine should be.
Absolutely.
Yeah.
And there was one man, he had got a few aches and pains. He's from Bangladesh, first generation immigrant. And I thought, I bet he's got vitamin D deficiency or stimulation. Being enthusiastic to find it, if we are.
Well, your index of suspicion was raised.
That's right. Yeah. Anyway, so I checked his blood level of vitamin D. I expected it to be low. And it came back really high. I thought, this is very strange. Anyway, he was coming back to see me a couple of weeks later.
Yeah.
So I said to him, I thought you were going to be short of vitamin D. He said, do you take vitamin D tablets, capsules? Never heard of it, he said. What's vitamin D? I said, well, do you eat a lot of fish? And he says, yeah, I love fish. I eat fish 3 times a day. I said, what sort of fish do you eat? He says, I eat Bangladeshi fish.
Right.
I said, well, where do you get it from? He says, I get it from Tesco in Accrington.
Right. Yeah.
So I go along to Tesco in Accrington. There it is, frozen Bangladeshi fish.
Right.
There's small white fish.
Sea fish or freshwater fish one?
I think there'll be sea fish. I'm not quite sure.
Yeah.
So, so it does show that you can get adequate vitamin D from fish. Yeah. We've got to eat an awful lot of it.
Yeah.
Now, there was another patient came to see me. The mobility wasn't very good. And he was a man with quite severe learning disabilities. And he was brought in by his carer. And I thought, well, he can't walk very well. He doesn't go outside, because I'd asked this question. I bet he's got vitamin D deficiency. So I checked his blood level. And, of course, he didn't have. So he came back and said, he's got very good vitamin D levels. Does he take any vitamin D tablets? No, he doesn't go outside. No, he never goes outside. And he doesn't take vitamin D. I said, does he eat fish? He eats prawns, he said. Prawns are the only fish, are the only food he eats. He eats prawns 3 times a day.
Interesting.
He's all he'll eat. And there he was.
Yeah.
And prawns, of course, feed on plankton. And it's the plankton that produce the vitamin D.
It's not the fish that produce the vitamin D. They're no more capable of producing vitamin D than we are. But they eat the plankton.
Yeah.
That produces the vitamin D.
When you think that if we're fully clothed, we don't produce vitamin D. Yeah. Well, fish are covered in scales. They can't produce vitamin D. Yeah. And they're fairly deep in the ocean as well.
Deep, so they get it from the plankton that's
near
the surface. They've got to eat it
from the plankton, the food chain.
That gets the sun.
Without the plankton, which evolved 1.5 billion years ago.
No, probably more. 2.5 probably. The
I think it was 2.5
great
billion.
oxygenation event.
I think it was, yeah. 2.5 billion years ago, you're right.
That's when the oxygen in the atmosphere...
Right.
Well, that's when we started getting oxygen in the atmosphere. Before that, there wasn't any.
But the plankton have no use for vitamin D. They produce the oil 7-dehydrocholesterol, which is their sunscreen. And so that molecule absorbs the energy from the sun, producing vitamin D, for which the plankton have no function, no use for it, because they don't have that level of immunity. And it was 1 billion years until the Cambrian explosion of complex life, that vitamin D was necessary.
For the complex life.
For the immunity to develop, and also for fish to develop a bony skeleton.
That's right. Yeah, before that there was no
bony skeleton.
No metazoans, no complex.
I think that was 300,000 years ago.
The Cambrian explosion started about 530 million years ago.
Yeah, that's right.
Yeah. We were talking about this last night. When we start thinking about how complex ecosystems are, it's just totally mind blowing.
Yeah, it is.
All these things that have to be in the right place at the right time, and vitamin D's become an essential part of that for all advanced life.
Yeah, indeed.
Yeah. So what should we do if you were chief medical officer? If Bobby Kennedy's coming in the United States, what advice would you give him?
I'd start off with women who are pregnant. Let's start with pregnant women. The first start is that no child should be born deficient in vitamin D.
Absolutely. Or deficient in anything, but yes, absolutely.
That is simple.
Yeah.
Simple public health initiative. Yep. Dead easy.
Yep.
And then we can expand it from there.
Yep.
And we can advise people to take vitamin D supplement in a sensible dose, realistic dose.
Yep.
But we've got to get the blood levels checked.
Yeah.
So we know if they're achieving a target blood level or not.
Yeah. So we need a cheap mass screening tool, ideally, don't we?
Well, I mentioned to you that I arranged about 5,000 vitamin D tests when I was doing my research.
Yeah.
And it didn't cost very much. Basically, it was a matter of buying the kit. And we bought the kit out of my small research fund for a few £1,000s. And then we could do the testing with the cost of reagents only.
Have you still got it?
I don't know if it's still there in the hospital.
Oh, I just see it sensing a business opportunity here. Yeah. So basically, you bought some fairly expensive equipment.
Yeah.
Then you needed to put some chemicals in it that were quite cheap.
Yeah.
And you did 5,000 vitamin D tests to produce all the wonderful graphs and things in that book.
Yeah.
And it was actually quite cheap once you bought the reagents.
That's right, once you bought the kit.
So there's no reason why this shouldn't be done.
I think the kit's cheaper now. You can look it up on the internet and find it's there. Yeah.
So all we need is the political will to do that, really.
Yeah.
And then ideally, because this is one of the frustrating things. We don't give medical advice anyway on this channel, but we can't say, most people probably need 4,000 units a day, but some people are going to need more, some people are going to need less.
Yeah, always the way.
And the only way we can know that, well, it's like alcohol, isn't it? You know, if you go into a pub, one guy, you're going to get, there's always some troublemaker who's completely blitzed after 2 pints.
Yes.
Whereas mates next door will be a bit tipsy after 8 pints.
Yeah.
That's
right.
It's the predisposition is going to vary massively depending on lots of factors. So
the main one is body weight.
Yeah.
You see, I mentioned before that 1 unit of vitamin D is the daily need of a 10-gram mouse.
Yes.
That's the definition.
This was developed before we could add the sophistication to weigh it.
We couldn't weigh it.
Yeah.
1 unit of vitamin D weighs 20 billionths of a gram.
Right.
You can't see it. You can't even see it, let alone weigh it. Until recently, that wasn't known. So it was by a biological assay. How much vitamin D is necessary to maintain a 10-gram mouse in what you might call good health?
Yeah.
Good skeletal health, that is, in fact.
Yeah.
So 1 unit for a 10-gram mouse, and that works up for someone who weighs 60 kilograms. It works out at 6,000 units a day.
Right, yes.
Now, that sounds a lot. So let's just halve it, should we? Let's be on the safe side and just halve it and say,
3,000 units
3,000 units a day.
So I mean, it's likely that 2,000 or 3,000 units a day is going to be safe for the vast majority of the population.
Yeah, but if someone weighs 120 kilograms, they need 12,000 units a day.
And as well as that, the vitamin D that they take will be sequestered into the fatty tissues.
It goes there, yeah, absolutely.
And won't be available to the rest of the body until the fatty tissues are already...
Yes, vitamin D is an oil.
Already
and
full
the
up.
fat cells of the body mop it up,
Yeah, so frustrating we can't do that, but so simple to test this, and this is a potential to revolutionise people like Abdul and Frank, who suffered appallingly.
Yeah, they did.
Throughout their lives with something which is so readily correctable.
Yeah.
You know, it's low-hanging fruit. Let's pick the low-hanging fruit.
Yeah, indeed.
Stuff that's cheap.
Yeah.
You know, so there's so many nutritional things, so many lifestyle things that can be corrected, and yet so much money is spent on research for high-tech, what I call clever clogs treatment.
You
know, sophisticated, specific treatments. And the other thing about I mean, if we can compare vitamin D with vaccination, for example, I mean, vaccination, I don't like the COVID vaccines, but other vaccines are probably necessary. We could argue about specific ones. At least I couldn't. I don't have the background knowledge. But what all vaccines do is they are highly specific. They are specific to a particular antigen, producing a particular type of immune response. And so and yet out in this, within half a mile of us, there'll be 10 to the 22 types of viruses.
Yes.
Never mind all the bacteria and everything. So you know, the human immune system. When I was learning immunity, they were told it could recognise 9 billion different foreign antigens, which
amazing, isn't it?
Sounds kind of reasonable.
So you've got to have something that works on all of them.
Yeah,
not one.
Exactly.
Yeah.
So why not bunk up your immunity for everything?
Yeah, absolutely.
And kill 10,000 birds with one stone.
Very much so.
Rather than taking 10,000 different...
Just the way to look at it. Yeah, indeed.
Preparations.
Yeah.
And
the thing about vaccinations also to remember is that you said a vaccination produces an immune response.
Yes.
That gobbles up and utilises vitamin D.
Interesting.
And the vitamin D molecule in the cells, 125 OHD, in the cell, can only be used once.
Yeah.
And then it's inactivated. So once we have vaccinations, they're going to knock down our vitamin D levels a bit.
And if they were low to begin with? Yeah.
And then if we have another vaccination and another vaccination, our vitamin D levels are going to go down.
So it's quite conceivable, as some data shows, that giving a particular vaccination may well protect you against that particular disease.
Yeah.
But predispose you to many other infections.
Could be by knocking down
by
your
the mechanism of lowering.
Yeah.
So when you give a vaccination, basically you are obliging. The body becomes an obligate vitamin D user.
And the vaccination itself, requires vitamin D. If it's going to produce an immune response, it's got to use vitamin D. It needs vitamin D.
Yeah.
And without vitamin D, the vaccination might not work very well.
No. So so if you're low in vitamin D to begin with, the vaccine won't generate a proper immune response because you're low in vitamin D. But in trying to generate an immune response, it will lower your vitamin D levels further, predisposing to a range of other infections.
Good, right? Yeah, absolutely.
So why the heck don't we give vitamin D with vaccines?
Absolutely, that's right. Should be done.
I've just worked that out just now. You know, in a shed, in the garden. You know, if I can work it out so great, you know, why don't people realise this?
Yeah. See, on your interview with Angus Dalgleish a little while ago, he mentioned that the treatment of cancer doesn't work properly unless someone's got vitamin D in the body.
Exactly.
Good levels of vitamin D.
Exactly.
Is the pancreatic cancer in particular he was talking about?
Yeah, he was talking about a particular pancreatic cancer with a particular chemotherapeutic regime. And for years they'd known there was two groups, people that respond to the chemotherapy and those that don't.
Yeah.
And they didn't know why.
Yeah.
And then he found out that it was simple. The ones that responded were vitamin D replete.
Yeah.
The ones that didn't respond were vitamin D deficient.
Yeah.
When he increased the vitamin D, everyone responded.
Yeah.
It's simple.
The vitamin D story, it's not rocket science.
No.
It's very, I can understand it as a simple physician in Blackburn. You can understand it. It's easy to understand.
Yeah. And again, that makes perfect sense because there's a huge immunological component to cancer.
Yeah.
Because
there is, absolutely.
I probably caught cancer between breakfast time and now.
Yeah.
God willing, I won't get it because my immune system will keep it suppressed.
Yeah.
There's so many. Can't remember. What was it? 70 trillion cells or something in the body.
Yeah.
One's bound to go wrong a few times a day.
Yeah, indeed.
But hopefully, if the immune system keeps that down, and the vitamin D isn't just so important for everything.
Yeah, this is the important thing, of course. Having good immunity is vital for good health.
Yeah.
Without good immunity, you do not have good health.
Simple as
that. And if you want optimal immunity, you've got to have plenty of vitamin D on board. You've got to have a good blood level of vitamin D.
Yep, brilliant.
About 100 nanomoles per litre.
Yep.
40 nanograms
40
per mil.
nanograms per mil, yeah. So let's get doctors to titrate people up to that.
Yeah.
Now, I've been inundated with requests for your book, David. What are we going to do about this?
Well, this book is no longer available.
Well, this is completely unacceptable.
We'd sold.
I'm afraid
we didn't print all that many.
The population is demanding this book.
Yeah. It's quite a simple. It's got loads and loads of pictures in it.
You've got plans to make it available in PDF.
What I'm going to do, though, it needs to be brought up to date. So I'm going to bring it up to date. And I hope to have it very shortly available. And I'll have it available as a PDF, probably not as a printed book.
Yeah. That's what I've done with my books now. When I changed from hard copy to PDF, I think in hard copy I probably sold about 10,000. And in PDFs, we're probably getting on for 1 million downloads now. So.
Is that right?
Yeah. The money's not where I'd like it to be, but that's okay. People are reading the book. Yeah. But in the meantime, the article that you've written on calcifidiol, we are going to make available.
Okay,
we can put a link to that if you're happy
indeed.
to do that. We can.
There is an economic cost as well, because to get we only printed about 1,000 copies of this book, which all went, and it cost me about £10,000.
Yeah.
Now, by the time we'd sent the books out
to all your mates
and paid postage,
you gave me one. Thank you.
That's right. Yeah, indeed.
Yeah.
And I think I got an income of about £3,000. An expenditure of £10,000, so it's just not economic. Because the cost of sending one of these to the United States, for example, is silly. And in this country as well, in fact, postage costs are very high. So the PDF is how it's going to be.
Right now, as soon as that's finished, can you send us the link?
Yeah, indeed.
And we'll publicise that, and we'll get people to download the PDF. And there might just be a link there to make a donation as well if people want to help cover cost.
I might
Always
do
welcome.
it. It's written in 10 parts, is this book.
Yeah.
And I might send it out as a PDF.
We could serialise
it.
We could serialise it on Substack or something
fine.
like that.
Yeah, might do it that way.
Because there's so much valuable stuff there that the world really needs to get hold of.
But the first bit of it, the prologue, is the case stories of Abdul and Frank.
Both infuriating to listen to.
Yeah.
Because so correctable.
That's right. There are a load of Abduls in this country.
Exactly.
There are a load of Franks as well.
Exactly. And all over the world.
Yeah. And in this country in particular, where there's no vitamin D for them.
Yeah.
It's very sad.
And it's still the same in Asia. I mean, huge swathes of the population in Asia like to be light-coloured.
Yes, they do. Yeah.
I was really surprised by this. I worked with nurses and doctors in Cambodia.
Yeah.
And they wore long sleeves.
Yeah.
They were this lovely light brown colour.
Yeah, that's right.
And they always wanted to be paler by... Why on earth they'd want to be paler, I don't know. But I said, if you're out in the sun all the time, you're going to be short of vitamin D. And even the doctors and nurses there hadn't realised this.
No, indeed. No, what was put to me by an Indian doctor I knew, or I know, was that being pale is a sign of being upper class.
Yes.
And darker skin is a sign of being poor.
Yes.
Because, of course, the wealthy people are indoors all the time, as we mentioned earlier on. Yeah. And the people who work outdoors, they're the dark skinned, the poor ones. And people don't like to be regarded as poor. you want to be regarded as more affluent.
Whereas in this country, if you've got a suntan, it means you can afford to go abroad for your holidays.
It does indeed, yes, that's right, yeah.
It's
just the opposite.
It's completely reversed again.
It is strange.
Both equally ludicrous and preposterous, I must say.
Yeah, that's right, John.
All skin colours are equally beautiful.
Yeah, absolutely.
But we just have to compensate for the fact that dark skin makes vitamin D way more slowly.
It does indeed, yeah.
This was an inconvenient, you know, I'd go out, I was in Africa last year, and my friend there, he works out in the sun all day with Fafa, and I said, in the morning I had to put sun cream on, and he said, "What are you putting sun cream? What are you doing?" I said, "Well, if I don't put this on, I get burnt." He said, "Do you?" Yeah, he had no idea. He had no idea. I says, "Look, I get burnt in the sun, but I make vitamin D quick. You don't get burnt in the sun, but you make vitamin D slowly."
Yes, indeed.
But this idea of putting on sun cream to protect yourself from the sun just wasn't in his. And he's a medical officer, but it just wasn't in his consciousness because he doesn't get sunburnt. but he does make vitamin D slowly. So since then, we've been aware of that, and we are hoping to do vitamin D tests.
Yes.
On the local population, because the Bantu area there, the skin colour is very, very dark.
Yes, it is indeed.
Or the sun is very, very bright.
Yeah.
So I think it's the same as here. If people are working outdoors all the time, we'll have enough. But I'm sure all the doctors and nurses, for example, and the call centre people, I'm sure they're all deficient in vitamin D.
Yeah, absolutely. Yeah.
But we won't know till we look. But it's just an interesting cultural difference.
Yeah, it is indeed.
Fascinating. Dr. Grimes, as always, we are very grateful. If you've made it to the end of this interview, how could you not make it to the end of this interview? It's just been fascinating all the way through. So, but thank you for watching, and thank you to Mrs. Grimes, who's patiently sat through this interview, which you may have heard before, but we appreciate it, and thanks for making the effort to
come. And thank you, John, for inviting us. Thank you very much.
Yeah.